A very good morning, dear students. Today, in this online lecture, we are going to study about diphtheria and whooping cough. So, let's start with diphtheria. Diphtheria is derived from Greek word diphtereti, which means leather or hide. It describes the coating in the throat. Let's start with its history. Now, in the 5th century, it's recognized by Hippocrates. In the 6th century, epidemics described. In 1883, diphtheria was described by Klebs. In 1920, toxoids were developed. It's also known as strangling angel of children. Agents. Now these are the ways through which this diphtheria can be transmitted. The first one is gram-positive road. They have no invasive power. They are powerful exotoxin. There are 4 types of it. The first one is gravis, metis, Belfanti, and intermedius. The beta phage is sensitive to penicillin, heat, chemical agents. Now, toxins mediate diseases. Now, this flowchart shows the sources of infection, which is further divided into cases and carrier. Under carrier comes subclinical and frank clinical cases, and under carrier comes temporary, that is of months, and second one under carrier is chronic, that is year. Agents. Now, infective materials are nasopharyngeal secretion, skin lesion. The period of infectivity, it's of 14 to 28 days from onset. The mode of transmission is droplet and direct. The portal of entry is respiratory and non-respiratory, and the incubation period of it is 2 to 6 days. Host. Children aged 1 to 5, they shift in age due to immunization. Now, under this, both sexes are affected, and the immunity, it's the material antibody in apparent infection. Resistance to disease depends on neutralizing antitoxin. Next is environmental factors. Winters is the season which favors its spread the most, although it occurs in all seasons. Let's talk about clinical features. It can be divided into two subparts: respiratory and non-respiratory. Under respiratory come pharyngobacillar and tracheobronchial and nasal. Under non-respiratory comes cutaneous, ocular and genital. This image shows the pharyngotonsillar type. Pharyngotonsillar type. The features of it are sore throat, difficulty in swallowing, low grade fever, mild erythema, localized exudate, pseudomembrane, and the severe form of it is bull-necked appearance, as you can see in the image below. Laryngotracheal type. Most severe form: hoarseness of voice, croupy cough, obstruction by membrane leading to prostration and dyspnea. Nasal type is the mildest form, localized to septum, turbinates. Nasal carrier are dangerous than throat carriers. Other forms: skin on finger and back of the hands, punched out ulcers, ocular, conjunctival, corneal damage, intestinal, dysphagia, and bloody diarrhea. And the last one is genital. This image shows the cutaneous type of it. Now, how can it be diagnosed? The first point under it is clinical examination. Direct microscopy using Albert's stain. Culture: Loeffler's serum slope. Fluorescent antibody technique. Toxigenicity testing by Alex Gel PPT. Diagnosis of susceptibility by Schick test. Now the important one, that is treatment. Treatment starts with isolation, neutralization of free circulating toxin by management of complications. Isolation. All cases should be promptly isolated for at least 14 days or until proven free of infection. At least 2 consecutive samples taken from site of lesions taken 24 hours apart should be negative before terminating isolation. Antitoxin. Antitoxin interferes with the action of toxin and modifies the attack. Dosage depends on severity of lesions, 20,000 to 1,20,000 units. Antibiotics. To terminate toxin production, to limit proliferation of bacteria, to prevent spread of organism to contacts, to prevent development of carrier state, and erythromycin. Now let's talk about the supportive therapy. Bed rest for 2 to 3 weeks. Avoid sudden exertion. Observe the point closely for changes in rate and rhythm of heart. Antipyretics and sedatives may be given if required. Easily digestible, high calorie diet should be advised. Treatment of contacts based on immunity status. Contact should be placed under medical surveillance and examined daily for evidence of diphtheria for at least a week after exposure. DPT vaccine. The route of administration is intramuscular injection. The site is lateral aspect of thigh. Dose is 0.5 ml. Interval of doses 4 weeks. Schedule DPT 1 to 3 ratio 6, 10, 14 weeks. Recently, pentavalent vaccines. Booster 1 is for 18 to 24 months and booster 2 is for 5 to 6 years. Additional boosters every 10 years. Now let's talk about pertussis, also known as whooping cough If we break it into two parts, that is per and tusis, then per mean extremely and tusis mean cough. History. It was first epidemic in 1578 stated by Guillaume de Belleau. In 1906, Bordet and Gangue were the scientists who isolated it. 1930 to 1940 was the period when the vaccine development started. Woof, loud crowing inspiration, and it's known as 100-day cough in Chinese. Agent. Bordetella pertussis is a gram-negative bacteria. Small, avoid Coccobacillus, non-motile, non-sporing. Survival in environment is very short. Produce exotoxins and endotoxins. Toxin mediated disease. Hosts are mostly females. Very few are male. Age incidence. Post vaccination introduction in school going children, that is 5 to 10 years. Immunity. Maternal antibody offer no protection. Secondary attack chances are 80%. Environment. Endemic disease with epidemic potential. Epidemics during winter season. Pathogenesis. The organism gets attached to the respiratory cilia and toxin causes paralysis of cilia. Mucopurulent exudate forms in the respiratory tract. This exudate predisposes to atelectasis, cough, cyanosis, and pneumonia. Organism causes local tissue damage and systemic effects mediated through its toxin. Diagnosis. Suspected on the basis of history and clinical examination, confirmed by culture, genomics, or serology. Blood investigation, elevated vital nasal secretion, IgM antibodies against toxins. Treatment. Avoidance of irritants, smoke, and other cough promoting factors. Antibiotics, erythromycin orally for 2 weeks or azithromycin orally for 7 days. Supportive treatment, supplementary oxygen, hydration, cough mixture, bronchodilator.